What if I told you that 1 out of every 2 people over 70 who go in for a routine test this year will be sent down a road they never needed to travel? Not because anything was truly wrong with them, but because a machine, a lab, or a scan found something that was never going to hurt them in the first place. Sit with that for a second, because by the end of this video, you are going to look at your next doctor's appointment completely differently. I am Dr. Franklin, and this is Health Wellness, the channel where we take the research most doctors don't have time to explain to you in a rushed 15-minute visit, and we break it down together in plain, everyday language. No jargon, no scare tactics, just the truth, the way I would explain it to my own mother or father. Here is something that might surprise you. More testing is not automatically the same thing as more safety. In fact, some of the most well-meaning, most routine checkups that adults over 70 are told to get every single year may be doing far more harm than good. I know that sounds backwards. We are taught our whole lives that catching things early saves lives. And in many cases, that is absolutely true. But something changes in the body, and in the math, once we cross into our 70s and 80s. And almost nobody sits you down to explain what that shift actually means. That is exactly what we are doing today. I am going to walk you through 6 specific checkups and screenings that many researchers and physicians now believe deserve a second look for adults over 70 who are feeling well. I will explain why the equation changes with age, I will share real examples of how this has played out for patients, and I am going to hand you a simple set of questions you can bring into your very next appointment that could completely change how your doctor talks to you. Stay with me all the way through, because the 4th one on this list is the one that surprises people the most when they first hear it. And the very last point is something almost nobody talks about, yet it may matter more than any test on this list. Before we dive in, tell me in the comments, where in the world are you watching from today? I love seeing how many countries and cities are represented in this community, and I read every single comment myself. Before I introduce you to that idea, let me tell you why I care so deeply about this particular subject, because it is not something I picked simply because it makes for an interesting video. Over years of reviewing medical literature and speaking with patients in this exact age range, I noticed a pattern that kept repeating itself, again and again. People who were genuinely thriving, walking, gardening, traveling, playing with their grandchildren, would go in for something described as routine, and would come out of that appointment carrying a new label, a new worry, or a new prescription that had nothing to do with how they actually felt walking in the door. I started asking myself, is this happening because these patients were truly getting sicker, or is something else going on entirely? What I found again and again in journal after journal is that a significant part of this pattern comes down to how screening medicine, designed decades ago primarily with younger and middle-aged patients in mind, behaves very differently once it meets a body in its 7th, 8th, or 9th decade of life. That single realization is what led me to build this entire video around one idea. Alright, let's get into it. But first, I need to give you one idea that will make everything else in this video click into place. I call it the 70-plus recalibration. Think of your body's relationship with medical testing like a bank account. In your 50s and 60s, every dollar you put into screening tends to come back with excellent interest. You catch a problem early, you treat it, and you buy yourself decades of healthy life in return. It is one of the best investments in modern medicine. But somewhere around 70, the exchange rate quietly changes, and almost nobody tells you when it happens. 3 things shift at once. First, many of the conditions screening finds in older adults are what researchers call indolent, meaning slow-moving, sluggish, unlikely to ever cause a symptom in the years you have left. You are far more likely to live alongside these findings than to be harmed by them. Yet once something shows up on a report, the system is built to act on it, not to simply watch it. Second, your body's ability to bounce back from an intervention changes with age. A procedure that a 55-year-old recovers from in 2 weeks might mean months of recovery, complications, or a permanent loss of independence for someone in their late 70s. And third, and this is the part that catches people off guard, is what I call the domino effect. A borderline result on one test quietly triggers a second test. That second test recommends a procedure. The procedure carries its own risks, and a person who walked into the office feeling completely fine can end up navigating a medical journey they never asked for, one small step at a time. Keep that recalibration idea in your mind as we go through each of these 6 checkups, because it is the thread that ties every single one of them together. Let's start with checkup number 1, the annual full body scan trend. You have probably seen the ads. Private clinics now offer whole body MRI or CT scans, marketed directly to healthy, active older adults, with the promise of catching cancer or disease before it even shows a symptom. It sounds like the ultimate peace of mind. Here is what those ads rarely mention. These scans generate an enormous number of what radiologists call incidental findings, small spots, cysts, or nodules that are picked up simply because the scan is looking at absolutely everything in your body at very high resolution. Research published in major radiology journals has found that a large majority of people who get one of these full-body scans will have at least one abnormal finding flagged, and the overwhelming majority of those findings turn out to be harmless. But once it is written on a report, you cannot simply unknow it. It generates anxiety, follow-up appointments, sometimes biopsies, for a finding that may never have caused you a single symptom in your lifetime. I think of a woman I'll call Margaret, a retired schoolteacher from Ohio, 73 years old, active, walking her dog 3 miles a day, feeling wonderful. Her daughter gifted her one of these whole-body scans as a birthday present. It found a small spot on her kidney. What followed was 3 months of additional imaging, a consultation with a specialist 2 hours away, and sleepless nights of worry before it was finally determined to be a completely benign cyst that had likely been sitting there for 20 years, doing absolutely nothing. Margaret told me later that those 3 months took a toll on her that no cyst ever could have. What to consider instead? If you have no symptoms and no strong family history pointing toward a specific concern, a targeted conversation with your own doctor about your personal risk factors is generally going to serve you better than a broad, unfocused scan of your entire body. Think of it this way. If you hired someone to inspect your house for problems and told them to write down absolutely everything they noticed, no matter how small, you would end up with a report listing a hairline crack in the driveway, a slightly loose doorknob, and a few shingles that could use replacing someday. None of those things mean your house is falling down. But if you did not know that, and someone handed you that list without context, you might panic and start tearing the whole place apart trying to fix things that were never actually urgent. A whole body scan works in much the same way. It finds every small imperfection your body has quietly carried for years, and without the right context from a trusted physician, that list can feel far more alarming than it actually is. And here is a pattern worth remembering as we move forward because it will show up again in almost every checkup we discuss today. The more sensitive a test becomes, the more it tends to find, and the more it finds, the more the system feels obligated to act on those findings, whether or not action is actually the wisest choice for that particular person at that particular age. Checkup number 2, routine colonoscopy past the age of 75. I want to introduce you to Walter, a retired mechanic from Arizona, 78 years old. Walter had 2 completely clean colonoscopies in his 50s and 60s. No polyps, no family history, no symptoms whatsoever. A new physician at his clinic flagged him as overdue and scheduled another one without much discussion. Walter went along with it because he trusted the system. The prep, that liquid you drink the night before to completely clear your bowel, hit him harder than it ever had in his younger years. By morning, he was severely dehydrated, his electrolytes had dropped to a dangerous level, and he ended up spending 3 days in the hospital before the procedure was ever even performed. He never did get the colonoscopy, and here is the irony. Current national screening guidelines from leading preventive medicine authorities actually recommend against routine colonoscopy screening for average-risk adults over the age of 75 with no symptoms and a clean screening history. The research is fairly consistent on this. Bowel perforation, an actual tear in the colon wall, occurs in roughly 1 out of every 500 procedures. In a younger patient, that is a manageable surgical complication. In a patient in their late 70s or 80s, it can mean emergency surgery and a recovery that changes daily life permanently. Meanwhile, the slow-growing nature of most colon polyps found in this age group means many would never have caused a problem in the person's remaining years. What to consider instead? Ask your doctor about a non-invasive stool-based test as a first step. And if you notice actual symptoms, blood in the stool, unexplained weight loss, a real change in your bowel habits, that is an entirely different conversation and one you should absolutely have promptly. Here is a pro tip most people never hear from their own doctor. Before agreeing to any procedure that requires a prep or sedation, ask specifically how your kidney function and current medication list were factored into that recommendation. Dehydration risk during PrEP is dramatically higher in adults taking diuretics or blood pressure medication, and it is rarely mentioned out loud. Checkup number 3, aggressive prostate and breast cancer screening in low-risk seniors. Let me be very careful and precise here, because this is a topic that deserves real nuance, not a blanket statement. Cancer screening has saved an enormous number of lives, and for the right person, at the right age, with the right risk profile, it absolutely still can. What the research increasingly points to is a serious overdiagnosis problem, specifically in average risk, symptom-free adults past their mid-70s. Overdiagnosis simply means this. Our imaging and lab technology has become so sensitive that it can detect cancers that are, biologically speaking, essentially dormant. Small, slow-growing, unlikely to ever spread or cause a symptom in the years remaining in a person's life. You would, quite literally, live the rest of your life with that condition rather than because of it. But the moment a word like malignancy appears on a report, the clinical machinery tends to move forward, regardless of whether that particular finding actually threatens the person's well-being. I think of Frank, a retired mechanic from Georgia, 79 years old, sharp as a tack, still out fishing every weekend. A routine PSA test came back slightly elevated. The follow-up biopsy confirmed a low-grade, extremely slow-moving prostate cancer. His urologist recommended radiation. Frank trusted that recommendation completely and moved forward with treatment. Within a year, he was dealing with chronic fatigue and urinary complications that had genuinely changed his day-to-day life. Research published in respected medical journals has found that a meaningful share of cancers detected through routine mammography in women over 70 were, in hindsight, clinically insignificant, meaning treatment provided no measurable survival benefit, only the side effects that come along with it. What to consider instead? Have an honest, direct conversation with your physician about your personal risk profile. If you have a strong family history or specific symptoms, screening absolutely makes sense. If you are average risk and feeling well, ask this exact question. If we do find something, what would treatment realistically look like for someone my age? And what result would we actually expect from it? That single question tends to completely reshape the conversation. I want to pause here for a moment because I know a topic like cancer screening can feel heavy, especially if you or someone you love has walked through a cancer diagnosis before. Please hear me clearly. Nothing I am saying today is meant to discourage anyone from screening who genuinely needs it. What I am asking you to consider is simply this: that the right answer for a 55-year-old with a family history is not automatically the same right answer for an 80-year-old with no symptoms and no family history at all. Context changes everything, and that context deserves a real conversation, not a one-size-fits-all protocol. If you are finding this valuable so far, do me a favor and drop the word yes in the comments below. It helps me know this information is actually landing with the people who need it, and it helps this video reach more people just like you. Checkup number 4, and this is the one that tends to stop people in their tracks the moment they hear it. Routine cardiac stress testing in people with absolutely no symptoms. On paper, it sounds completely sensible. You are 72, your doctor wants to confirm your heart is doing well, so you walk on a treadmill or receive a medication that temporarily stresses the heart while it is monitored. Here is what almost nobody explains beforehand. Cardiac stress tests performed on people without any symptoms have a false positive rate that can climb above 40% in certain populations. That means nearly half the time, the test suggests a problem exists when the heart is actually functioning just fine. But medicine is not built to simply shrug off an abnormal result. That false alarm often launches the next step: a cardiac catheterization, where a thin tube is threaded through a blood vessel, usually in the wrist or groin, directly toward the heart. It is a real procedure with real risks, including bleeding, vessel damage, irregular heart rhythm, and in rare instances, it can actually trigger the very cardiac event it was meant to prevent. Here is where it becomes even more counterintuitive. If that catheterization finds a partial blockage, and partial blockages are extremely common in adults over 70, many with zero symptoms, the person may end up receiving a cardiac stent. Multiple large clinical trials have found that stenting in patients with stable, symptom-free coronary artery disease did not reduce heart attacks or extend life when compared with medication and lifestyle changes alone. Read that again. The stent did not outperform medication, yet it came with its own procedural risk, plus a lifetime commitment to blood-thinning medication and its own bleeding concerns. So the journey becomes this: feeling completely fine, routine test, false alarm, catheterization, stent, blood thinners, ongoing monitoring for the rest of life, and statistically no better off than a person who simply managed their risk factors with medication and a daily walk. What to consider instead: if you have no chest discomfort, no unexplained shortness of breath, and no dizziness during activity, a conversation about optimizing your actual risk factors, blood pressure, cholesterol, blood sugar, movement, and sleep tends to deliver far more genuine benefit than a routine stress test looking for a problem in a population where problems are extremely common and intervention does not always help. Checkup number 5, routine bone density scanning paired with automatic long-term medication. I want to be careful here too, because osteoporosis is real, and falls genuinely are one of the most serious threats to independence in older adults. I am not questioning that reality even slightly. What I am questioning is the automatic pipeline that often follows a low bone density result in patients past 75. A scan detects low bone density, a bisphosphonate medication gets prescribed, and the patient takes it for years, assuming full protection, without anyone mentioning what research has found about long-term use. Long-term bisphosphonate use has been associated with a rare but serious complication called an atypical femoral fracture. Essentially a spontaneous stress fracture in the very thigh bone the medication was meant to protect. These fractures can be severe and often require surgical repair. These medications have also been linked in rare cases to a painful jawbone condition that is genuinely difficult to treat. Meanwhile, the single most effective intervention for preventing fractures in older adults is not a pill at all. It is fall prevention. Balance training programs, and Tai Chi in particular, have been shown in multiple studies to reduce fall risk by close to 50%. Removing tripping hazards at home, installing grab bars in the bathroom, reviewing medications for side effects that cause dizziness, getting vision checked annually, and making sure you are getting enough protein and vitamin D. These interventions reduce fracture risk meaningfully, with essentially zero downside. I am not saying medication is never appropriate. For someone who has already had a fracture or has a very low bone density score, it absolutely may be the right call. But for an active 74-year-old who has never broken a bone and feels great, moving straight to long-term medication without first exploring fall prevention is a conversation worth having, not something to accept automatically. What to ask your doctor. Before we discuss medication, can we go through my personal fall risk factors together? And what is the actual measured benefit of this medication compared with a structured balance and fall prevention program? Here is a warning worth remembering. If you are ever prescribed a bisphosphonate, ask your doctor or pharmacist about the recommended maximum duration of use for someone your age, because ongoing research suggests a scheduled break, sometimes called a drug holiday, may reduce long-term risk for some patients. This is a conversation to have with your own physician, not a decision to make on your own. I think about a woman I'll call Helen, 81 years old, living independently in a small town outside Manchester, England, someone who had never broken a bone in her entire life and still gardened for 2 hours most mornings. A routine scan flagged low bone density, and within the same appointment she walked out with a prescription, no discussion of balance training, no mention of a fall risk assessment, nothing beyond the pill itself. It was only a year later, when she brought up persistent jaw discomfort with her dentist, that anyone connected the dots back to the medication. Her dentist encouraged her to raise it with her physician, and together they eventually decided a supervised pause made sense for her particular situation. I share her story not to frighten you, but because it illustrates exactly why that one simple question, what would a structured fall prevention plan achieve compared with medication alone, deserves to be asked before a prescription is written, not after. Checkup number 6, and this is the one that receives almost no attention anywhere online: asymptomatic carotid artery ultrasound screening. A carotid ultrasound examines the large blood vessels in your neck that supply blood to your brain. The logic seems airtight. If we find a significant narrowing, we can surgically clear it and reduce stroke risk. In practice, for people without any symptoms at all, the picture is far more complicated, and in many cases, far riskier than it first appears. The surgical procedure used to treat a carotid blockage carries roughly a 2 to 3% risk of actually causing a stroke during or immediately after the operation, and that risk climbs higher in older adults with other health conditions. Leading preventive health authorities explicitly recommend against routine carotid screening in people with no symptoms, no episodes of temporary vision loss, and no history of mini strokes. Their analysis has consistently found that in symptom-free individuals, the risk of surgical harm outweighs any potential benefit. Here is why. A great many people past 70 have some degree of narrowing in these arteries that has been there quietly, stably, for years without ever causing a single problem. Screening for it finds it, and a well-intentioned specialist may recommend fixing it. But the surgery meant to correct a blockage that was never causing symptoms can, in rare cases, actually dislodge a small piece of plaque that travels straight to the brain, causing the very event it was meant to prevent. I am intentionally not sharing a single dramatic case story for this one because the documented pattern across the research is significant enough on its own that it does not need to be reduced to one anecdote. What to consider instead? If you have no symptoms of stroke or a mini stroke, no sudden vision changes, no facial drooping, no sudden arm weakness, no unusually severe headache, then routine carotid screening is generally not something the evidence supports pursuing. The stronger investment is managing the actual modifiable drivers of stroke risk, blood pressure, blood sugar, smoking cessation, irregular heart rhythm management, and staying physically active. And if you ever do experience any neurological symptom, even one that resolves on its own within minutes, please seek evaluation immediately, because that genuinely does change the entire picture. Now here is something I promised you at the start, a simple framework you can carry into any appointment. I call it the 5-question checklist, and I want you to write these down, save them in your phone, whatever it takes to have them ready the next time a screening test is recommended, especially if you are over 70 and feeling well. Question 1. What is the false positive rate of this particular test for someone my age? This tells you how likely the test is to trigger a cascade of unnecessary follow-up procedures, even when nothing is genuinely wrong. Question 2. If this test finds something, what would realistic treatment actually look like for someone my age and health status? This shifts the conversation from simply finding something toward what would actually happen next. Question 3. What is the procedural risk of whatever treatment we would likely pursue? EI.